All right, let's jump right into a really high-stakes clinical challenge. For the next few minutes, I want you to imagine you're part of the team in the ER, and a really critical case is about to come through those doors. We're going to walk through it, step by step.
So that's the call from dispatch. It's pretty vague, right? It could be anything. A medical problem, a trauma, an overdose. Who knows? But the clock has officially started, and every single decision we make from here on out really matters. Okay, the call comes in to you. Before that patient even hits the door, your brain should be firing on all cylinders, running through all the possibilities. What are the immediate, life-threatening things you need to be ready for? Let's get right into the fundamentals.
Look, it doesn't matter how weird or complex the case seems. You always, and I mean always, start right here. This is the absolute bedrock of emergency medicine. Before we even think about why he's unconscious, we have to make damn sure he stays alive.
This is just non-negotiable. You can't diagnose a patient who isn't breathing or doesn't have a pulse. Simple as that. Is his airway open? Is he actually moving air? Is his blood pressure stable? Everything else has to wait.
Okay, so the paramedics have already done some fantastic work on scene. The fact that a jaw thrust helped his breathing, that tells us his airway was probably just blocked by his tongue falling back, which is super common. They put him on a backboard, assuming a potential neck injury. Always the right call when you don't know the story. They've got him on oxygen, started an IV line, which is our lifeline, and they tried naloxone to rule out an opioid overdose. Smart moves all around. All right, the patient's here. He's stabilized for now. This is where the real fun begins. It's time to put on our detective hats and start peeling back the layers of this mystery, right at the bedside.
So the first big number we get is his GCS score. It's a 7. Now, this is a universal scale for consciousness. And the key thing to note is that any score of 8 or less is, by definition, a coma. This number screams severe brain injury, and it tells us, flat out, that this man cannot protect his own airway.
So how do we actually get to that number 7? It's not just pulled out of thin air. He gets a 1 because his eyes aren't opening at all, a 2 because he's only making sounds, not actual words, and a 4 because he withdraws from a painful stimulus. See, it's not just a number, it's a very specific snapshot of his brain function right at this moment.
Taking a look at his vitals, they're not terrible, but they're not great either. His breathing is a little fast, and he's needing a good bit of oxygen to stay in the 90s. But here's the big one. His glucose is 80. That's fantastic news, because we can now officially take low blood sugar off the table as the cause of his coma.
And this is where the plot really thickens. Of course he smells like alcohol, we see the wine bottle, it's easy to just anchor on that diagnosis, right? But hold on. We also find a full bottle of phenytoin. That's an anti-seizure medication. That's a huge clue. Then you see the urine-stained pants. Could that be from a seizure? And those old scars on his head, they tell a story of prior trauma, making him way more vulnerable to a new injury.
Right now, it would be so easy to just chalk this up to alcohol and let him sleep it off. But that would be a catastrophic mistake, because one single finding on our exam is about to change the entire game and turn this case into a true life-or-death emergency. And here it is, his pupils. They're not equal. The left one is about 3 millimeters in reactive, which is normal. But the right one, it's huge, 6 millimeters, and it's fixed. It does not react to light. This is what we call a blown pupil, and it is one of the most terrifying signs in all of medicine. This is not just alcohol.
So this is our new working diagnosis, and it's a scary one. That blown pupil tells us that there's something on the right side of his brain, blood probably, that's swelling so much it's physically pushing the brain down and crushing the brainstem. This is an active process that will kill him in minutes to hours if we don't stop it.
So let's just compare these two side by side. If it's just an alcohol stupor, you'd expect a symmetrical exam. Yeah, he's out of it, but his pupils should be equal and reactive. With brainstem herniation, the key word is asymmetry. The pupils are different. One side of the body might be posturing, and crucially, the patient is getting worse, not better.
So because of that one finding, those asymmetrical pupils, this is no longer just a medical case. This is a trauma activation. We need surgeons, we need an operating room on standby, and we need to get this man to a CT scanner like yesterday.
Now, while the trauma team is rushing down, we aren't just standing around. There are still things we can and absolutely must do at the bedside. We're going to give what's sometimes called the coma cocktail, a series of drugs to reverse common, treatable causes of unconsciousness.
And this brings us to a classic board exam question. But it's more than that. It's a critical patient safety issue. For a patient like ours, who's likely malnourished from alcohol use, getting this sequence wrong can cause devastating, permanent harm.
Here's why this is so important.
The brain needs thiamine to metabolize glucose. If you're thiamine deficient and we suddenly flood your system with sugar, you force the brain to burn through its last tiny reserves of thiamine. This can trigger a catastrophic neurological syndrome called Wernicke's encephalopathy. It's an injury that we, the doctors, would be causing.
So you absolutely have to remember this order. First, always, airway and oxygen. Then you push the thiamine. Only after the thiamine is in is it safe to give the glucose. Naloxone is the fourth piece, which we already did. This sequence protects the patient from iatrogenic harm.
Okay, let's zoom out for a second and nail down the key takeaways from this case. This is the stuff you absolutely need to have locked and loaded, not just for your exams, but for real-life clinical practice.
Anytime you walk into a room with an unconscious patient, you have to turn into a rapid-fire detective. These are your first questions. Trauma? Seizures? Diabetes? How long have they been down? And look around. Look at the scene. Look in their pockets. Are there pill bottles? A medical alert bracelet? The clues are almost always there.
Here is a huge piece of advice, both for your tests and for the rest of your career. When you're thinking about what could be wrong, always think worst first. What are the things that are going to kill this patient in the next 5 minutes? Start there. Rule those things out first.
And what are those big killers? Now, here they are, the top 3. A bleed inside the head, like our patient, a massive stroke cutting off blood flow to the brain, or a toxic overdose. Your initial workup has to be laser-focused on finding or ruling out these 3 things immediately.
So let's end with this question. If you take only one single thing away from this entire case, let it be the answer to this. It's the asymmetrical pupil. That one sign cuts through all the noise. It separates metabolic and toxic problems from a structural catastrophe inside the skull, and it is your #1 sign to act, and to act fast.